away so that when she turns, she stays somewhat in the middle of the table. Okay, go ahead and turn all the way up on your left. Now see how she scooted her hip? So scoot your hip towards me a little bit. So I'm going to try to keep her body straight, but people always get cattywampus crooked on this position. So again, when you're placing the sponge, don't place it all the way against the back, about halfway out. Okay, and then have her roll back. So you want the hips and the shoulders in the same plane. Now people tend to have their hips over too far. I'm going to scoot her over a little bit. Okay, and she was adjusting herself this morning because she wasn't comfortable. So you have to get them comfortable, but you also need to keep them in the position. Bring your shoulder up again. Okay, now roll back. See how that sponge kind of moves? So it moved her position. So still, she's a little bit at a diagonal. Would you agree from up there? Okay, so the easiest way to fix this is go like that. Because if you start having scoot the hips, scoot the shoulders, because I'm saying 1 minute, and you're not even close to getting them in the right position. Yes?
If you can adjust the patient so that they're straight, but is it okay to also move the tube so that it comes out?
On the APs and the obliques, we don't usually put the tube diagonal.
Well, not just specifically.
Oh, you mean because you can't move the patient? Right. You know, I mean, some people may do that, but on the CR and the DR, they're not so keen about the diagonal collimation. So, and I don't know that the radiologist would like to see it like that. They probably want to see it straight up and down. You know, so, I mean, sure, if you really can't get them straight, then get your collimated turn a little bit. Okay, now pay attention to the arm. Some places have you do this, which is okay. You don't want to have them bend their elbow like this because then you're risking getting it into the anatomy. I usually just have them keep their hand, like their hand on their hip and their elbow next to them, which is also giving us an indication of what area. Elbow. If you do that, what she just did, see how it drops the shoulders down? And what I often see are the shoulders are too flat, almost AP, and the hips are too rotated. So you've got to try to make sure and maintain this body in a 45-degree position, okay? All right, so now that we got her all settled here, get the light on here and just relax your arm up here. Okay, so now I'm going to palpate for the iliac crest, and that's hitting the side of my finger here. And which side do I center on? The side down or side up? Up. Right. Okay, so my finger's here, so I can check my level up and down here. Right, so here's the iliac crest. I'm going right next to my finger, so it's 2 inches above the iliac crest. And now I'm going to place my hand on the ACES and go 2 inches into the ASIS. Shield. Thank you. So, when you're doing this palpation, some people may go like this. Maybe because I'm right-handed, I've always done it with my right hand. And most normal table locks are up here. So that would be another way to move your table, because I don't know that many tables that really have a floor lock, right? So that way I've got my hand still in this right position. So if I'm like this, what I want you to be careful of, see how the rest of my hand's up? You know, I'm just using like the pads of my fingertips. Don't be laying your arm across the anatomy, particularly on the male patients. Right? We want to stay away from that area. Okay, I've had men get erections during L-spine imaging. And very venomous, which is a whole other story. But, you know, young men are in for back x-ray, and there's just, you know, they're not used to all this attention, and all of a sudden, you know what that means, right? So, it can be a problem later, because it gets in the way of the anatomy, you know, so.
You're making me
sorry. I'm like giving you the facts, that's all, right?
Just the facts, man.
That's right. Okay, didn't say anything inappropriate, I'm just telling you the truth. Okay, so where is the light in coordinates to her earlobe? Turn it just a little bit. No, up. Oh, there. So it should be right at the earlobe, right? Okay, what's another landmark that we can use?
The rib?
Yeah, the end of the rib, L1. Now again, be careful, you know, we don't want to be touching other areas there, but okay. The question came up this morning, and I think it's kind of common in Santa Monica. A lot of people don't have their pelvis. They've taken some kind of surgical intervention and taken a good chunk of their pelvis out. So what if you don't have an ACES to palpate? And they need to do an L-spine.
The rib?
Yeah. Or also look at where the light is. It's, you know, about 4 inches in from the side of the body. So you'll learn to adapt when you can't exactly find the landmark that you need. But the palpation, understanding the palpation is important. Okay, so what am I demonstrating in this position?
For RPOs, the right side.
So remember I told you typically we mark the side that's down. And again, you know, this is probably not the best place because we want the SI joint, so you probably want to put your marker up here. Since this is demonstrating the RPO, could I put the right marker over here?
No,
Aren't I demonstrating the right zygos?
the right side.
That's right. You never mark the right marker on the left side. Keep the right on the right and the left on the left. Okay? One more little, and I'm going to call it an Augieism, because he came up with this morning. I said it, but he made it funnier. Was when we're rotating the patient, typically we're not angling the tube. Yeah, in this section we're not. So you either move the patient or move the tube.
My favorite answer is yes.
Well, when you get into the skull and
Yes.
stuff, it's a whole nother world, but I'm just talking about what we're covering right now. Okay, if you're angling the tube, then you're probably not turning the patient. That's going to make more sense in a minute when I get to the SI joints. Okay? I'm trying to give you all these bits of information where people mess up. So the biggest positioning error I see with this is the shoulders are too back far and the hips are too up. So there's an over-rotation of the pelvis. So remember we talked about this last week with or a couple weeks ago with the ribs. You can have this knee bent for comfort, and this knee should be fairly straight. You could have them flex it a little bit if it's straining, because this probably would strain your back if you were actually, you know, had a back problem, which is probably why you're in here getting an X-ray, right? But don't do it too much. You should never see the knees on top of each other, because if you do, you're going to over-rotate the pelvis, and it's going to be fail, and then you're going to argue with me for a year and a half. You can
I would
dispute.
never argue with you.
Never say never. Okay. So we've done the RPO. All right, go ahead and relax. Scoot over towards me a little bit. And now we're going to do the LPO. And turn. Okay, so remember, this is not the 45 degree, this side is. Okay? Okay, so again, I'm going to have to go ahead and relax down. All right, so I'm watching to make sure my hips and my shoulder are in the same plane.